and I'm very pleased to introduce our first speaker for today. Kathleen Crim has worked as a registered dietitian and certified nutrition support clinician and currently manages the Home Parenteral Nutrition Program at Miami Transplant Institute. She oversees all patients on TPN that are part of the intestine and multivisceral transplant programs, as well as the intestinal rehabilitation program. Previously, she has worked as a clinical dietitian with a focus on trauma, surgical, critical care at Grady Memorial Hospital, as well as a clinical dietitian with a focus on critical care and acute nutrition at Northside Hospital. Prior to working in the clinical setting, she worked as a wellness resource specialist for Morrison Management Specialists, where she developed and implemented wellness programs for hospital associates. She currently is a board member for the Georgia chapter of Aspen, and we are very excited to have her present on PN nutrition today. Please welcome Kathleen Crim.
Thank you, and thank you for having me. I have one disclosure that I'm a Fresenius Kabi speaker. Objectives today, we are going to discuss appropriate dosing for parenteral nutrition, macronutrients and micronutrients for adult patients. We're going to discuss dosing for macronutrients and micronutrients for pediatric patients and within their different age ranges, as we know they change depending on their age. And then at the end, we'll discuss the types of lipid injectable emulsions that are available and the appropriate dosing of each one. So just to begin, just a little overview, as we all know this, but it's always nice just to have a refresher. Carbohydrates are going to be the primary source of energy in our parenteral nutrition. You're going to want to have 50 to 60% of your total calories are going to come from this. And as we know, we get 3.4 calories per gram. Protein is not a primary energy source. We're going to want to meet protein needs. This is going to provide 4 calories per gram. And then we have our fats, depending on which type of lipid you choose to use, depending on the patient. And then we'll have the vitamins, trace elements, and electrolytes. And then for our pediatric patients that are solely dependent on PN, their daily requirements are usually going to be a little lower. So you're going to meet, on average, provide 80% of their nutritional needs with the PN. So parenteral nutrition composition, when calculating your PN, you want to identify the volume desired. And then you want to calculate the calories. And this is something I know we learn the basics, but it's just important to go back to the basics sometimes. Just from experience with working with other dietitians, we have a lot of patients that come to us from other facilities, and you see a lot of different things happen. But first you want to calculate the calorie needs. Then you want to figure out their protein needs. So provide that with the amino acids. As we know, that's not going to contribute to the calories, but I've seen it time and time again where you have someone who says, oh, we can increase their calories because they need more, and they have, we can go up in their protein. That's not something that is going to provide, that's not where you're going to get your calories from. You want to make sure you just meet their protein needs. After that's met, calculate their lipid needs depending on which type of lipid they are receiving. And then after that, you're going to get the remaining calories from your dextrose. You obviously, when you're calculating your dextrose and trying to figure out the remaining calories, you need to factor in the glucose infusion rate. And as well, when you're calculating the lipids, which we'll touch base on later on, calculate the lipid infusion rate and make sure you're not exceeding it. So we'll start with the adult macronutrient dosing. For energy and fluid needs. So their total energy is going to be 20 to 30 calories per kilo. Your obese patients, you're going to want to provide 22 to 25 calories per kilo based on their ideal body weight. And obviously, you see these ranges, and some people are going to require less than this. Some people are going to require more than this. And it's just factoring in their condition. Are they eating by mouth? Are they solely dependent on PN? Where in that range are they? And these are just ranges, and I can, we have patients that I work with in our transplant program and our rehab program that, some of the adults do exceed this 30 calories per kilo, and you're like, whoa, you're not supposed to be doing that. That's too much. It's going to hurt their liver. It's going to do this. It's going to do that. And that's where the importance of monitoring their labs, making sure you're not exceeding certain recommendations. Fluid for a stable patient, usually they'll require 30 to 40 mLs per kilo per day. Again, this is a range. You may be providing more than 40 for your bowel patients that are losing excess fluid and have, liters and liters of output daily. They might need more than 40 mLs per kilo. I have a patient right now who puts out 6 to 8 liters a day through her ostomies, her drains, and everything. So it's taking into consideration that fluid output and making sure you're meeting it. And also depending on if you have a critically ill patient, trauma patient, or septic patient, you want to be able to provide the amount required so they can receive the adequate macronutrients. So it might not fall within this range, but making sure that they are still getting the protein, the carbs, and the lipids that they need. So for amino acids, your stable patient is going to require anywhere from 0.8 to 1.5 grams per kilo per day. Again, it's a range. You can see on the other side of your screen, there are modifications that can be made. Your critically ill trauma and septic patients are going to have a range from 1.2 to 2.2 grams per kilo. So I did list some specific conditions that do require modification. Your traumatic brain injury patients are going to have a wide range depending on their what's going on, anywhere from 1.5 to 2.5. Your burn patients, 1.5 to 2 grams per kilo. Your acute kidney injury, that's going to be a range also, 1.2 to 2. And your CRRT patients, you want to add 0.2 grams per kilo per day to what their normal recommendation is without exceeding 2.5 total. And then your dialysis patients on average are 1.2. Your liver failure patients, this is going to be a range also. It's going to be 1.2 to 2 based on their dry weight. So as we know, they have a lot of fluid and ascites, and you don't want to base their protein needs on their actual body weight. You want to try to find a what their dry weight is, and that can be hard. Some patients know it, some patients don't. They're like, I've just fluctuated for so many years, so I'm just kind of guessing with what my dry weight is, and trying to find out, if they don't have a dry weight, you could always use their ideal body weight. And your obese patients are going to require more protein, but you're going to base it on their ideal body weight. Dextrose in an adult patient, if they're stable, make sure you're keeping that GIR between 4 and 5. In your critically ill patients, trauma patients, and septic patients, keeping it less than 4. Electrolytes. This is something I wanted to touch on because we do see this with a lot of our outpatient home patients, patients that are transitioning from the hospital to home, what to look for once they are home, and also what to look for while they're admitted too, especially when you have that the benefit of having labs every day while they're in the hospital, and once they go home they're not going to have those labs every day. So with the acetate and chloride, just make sure you're maintaining an acid-base balance. If you have a patient with GI losses, of bicarb, you're going to need to increase the amount of acetate. And we do see this a lot with these GI losses, patients with high GI losses. They are going to require a higher amount of acetate in their formula. It's important to remember your patients that are at risk for refeeding syndrome. They may need more magnesium, phosphorus, and potassium in the beginning. This can eventually be lowered, but you want to make sure you're getting those labs done, making sure they're getting adequate amounts prior to starting them on the PN, but then just knowing that initially they may need higher amounts of these 3 electrolytes. Your GI losses are also going to increase the amount of magnesium, sodium, and potassium in the formula. And then your patients with a high protein intake, they can require more calcium than your average patient. So for your adult micronutrient dosing, here's the list of standard daily requirements for vitamins. And most of us are adding the 10 mLs or should be adding the 10 mLs per day in the PN, or if you need to, depending on what their condition is, cut it in half. But this is what the standard daily requirement is. Conditions that would require additional or potential modifications would be patients with wounds needing to modify the vitamin C and the riboflavin. Your patients with diarrhea, you can see some of them will need a modification in folic acid. We do have, with some of my patients, my GI patients, you do see that deficiency occur. So you just need to keep in mind that, they are getting folic acid in the multivitamin, but if they are having increased diarrhea, they may need additional folic acid. Here are your trace element daily requirements. Again, it does range depending on, what's going on with the patient. Conditions that would require modification would be your GI losses. So if you have a patient that has increased GI losses, they might need more than 3 to 5 milligrams of zinc. We have a lot of patients that require 10 to 15 milligrams of zinc just because their losses are so high. Your hepatic failure patients, you want to make sure you're monitoring their copper levels. They may not need the copper, or they may not need some of the other trace elements just because it's dependent on where they are with their liver failure. And wound healing. Wound healing is going to increase some needs of trace elements. And later on, we'll discuss, the monitoring of trace elements and how often to do so. Your pediatric macronutrient dosing. So this is for infants less than 1 year. Their energy needs, you are going to want to initiate between 42 and 57 calories per kilo, with the goal being 90 to 110 calories per kilo for growth. And obviously, as they grow and as they get, as they get older, you may adjust that. Their protein and dextrose. You will initiate their protein at 1 to 3 grams per kilo, with the goal being 3 to 4. And then their dextrose, you'll initiate at their GIR at 6 to 8, and then their goal is 10 to 14 with a maximum of 18. Your term infants, you can start their protein at goal. You don't have to increase them up to goal like the preterm. And then the dextrose is the same for the term infants. Children between 1 to 10 years old, you're going to initiate their protein at 1.5 to 2.5 grams per kilo, and you just start them wherever they need. You can start them at goal. You don't have to worry about advancing. Their dextrose, if they are going to require an increased amount of dextrose, you don't want to start them right away at their goal. So you can start them around 3 to 6, advancing them by 1 to 2 until you get to that goal GIR. Adolescents, this is going to be their protein range. It's 0.8 to 2 grams per kilo. Again, you can start them at their goal. You don't need to worry about advancing them. And then the dextrose, you are going to want to advance as well. You're going to initiate them at usually around half. And then as they tolerate and as you're monitoring the labs, you can advance them to their goal. Fluid needs for pediatric. This is, here's the fluid needs with the holiday Seeger method. What we're all used to. This is, 1 to 10 kilos, they get 100 mLs per kilo. And then for the second 10 kilos, you add 50 mLs per kilo. And then once they're over 20 kilos, you do 1500 mLs plus 20 per kilo. And there are a few things to consider when factoring the fluid needs. That's just a guide. You're going to have patients with different conditions that aren't going to fall in that guide. Most patients, as we know, a lot of them just don't fall in the regular recommendations. So if you have a patient with excess losses, so they have increased G-tube output, they have high ostomy output, they don't have a colon, they don't have an ileum, they have increased emesis, you want to pay attention to their I's and O's. These excess losses are going to require more than what the recommendation is for fluid. And then also, you want to provide additional fluid for maintenance when you have a febrile patient, a patient that does have increased activity, a patient with burns or dehydration. A lot of our pediatric patients in the summertime, they're active, they're playing outside, it's hot out, so they're sweating more. And we do see during those summer months or when it's really hot in Florida that we need to go up on their fluids a little more. And then we can come back down if we need to. And this actually is the same for the adults too. Just knowing that, seeing what they're doing, if they're outside, if they're active, what are their losses, just making sure you tailor it to them. And with the peds, they can't necessarily tell you. So, it's monitoring their labs, talking to their parents. Some of them will tell you, I'm really thirsty all the time. And then that's, our cue to, okay, you may need more fluid, let's check your labs and then increase if we need to. Patients that are going to require less than maintenance are going to be your patients with ascites, your cardiac patients, fluid overload, where there's third spacing. So these are going to be the ones that, instead of providing them one-time maintenance, you might be providing them, 80% of their maintenance needs. Or sometimes less. Our short bowel patients, this is one that, when I started working with the short bowel patient population, it was like, oh, you're giving them a lot of fluid, but then you see that you do need it. They're going to have higher needs. You might go sometimes up to 1.5 times maintenance. Even we have had patients that require 1.8 times maintenance. So just knowing their condition and knowing their lab values. Pediatric micronutrient dosing. Their vitamin, here's the vitamin recommendation. Oh, sorry, I didn't mean to just change the slide right away. Here's the vitamin recommendations. So depending on what their weight is. So if you can see if they're less than 1 kilo, you're going to provide 1.5 mLs of MVI. If they're 1 to 3, you're going to do that 3.25. And once they get greater than 3, you can provide 5 mLs. Again, just knowing what their condition is and do they need all of it? Do they only need half? And paying attention to their weight. And then you can see on the other side, the recommendations from the American Medical Association vary just a little. They say that your pediatric patient that's less than 2.5 kilos, you can go ahead and give them 2 mLs per kilo. And once they get over that 2.5 kilo weight, you can go up to 5. Here's going to be your trace elements for pediatric patients. I like this chart. It's easy to follow. I will be honest, I use this chart pretty frequently in my practice just because we have patients that range from preterm right out of the NICU to our adolescents. So just trying to figure out where their dosing is with their trace elements. A lot of our patients, we individually dose their trace elements given their GI conditions and their losses. So we find that we can't necessarily, they're not going to get what they need to and that they need more than what they should. So we kind of reference this a lot with us, but you can see I don't need to, this is kind of self-explanatory. I can go, I don't need to go through each one of them one by one, but it is nice that it has your preterm neonates, your term neonates, your kids between 10 and 40 kilos, and then your adolescents that are greater than 40. Your trace elements that are going to require modification for pediatric patients, you're going to want to increase their zinc with GI losses. This is the same as in adults. And some of the patients with renal failure, you will see lower zinc levels, so they might require an increased amount. Copper with biliary losses, high jejunostomy output, external biliary drainage, and our high GI loss patients. They might have lower copper levels than normal, so you might have to increase them a little more than the recommended amount. And then you want to decrease or remove copper and manganese with patients that have hepatic dysfunction and cholestasis. So your vitamin and mineral lab monitoring, this is something that it's kind of difficult to find recommendations. You know, there are recommendations out there on when to monitor them and how often. A lot of people, it's specific to the institution that you're in. This is how we monitor them in our institution. If they're on parenteral nutrition, we'll get iron studies every 1 to 3 months. If these patients are requiring iron infusions, then we will get iron studies once a month until their levels go back to normal and then they are not requiring the iron infusions. Your copper, 1 month after PN initiation, and then every 6 months. I will touch on some of these that when they do say every 6 months, depending if you know you have a patient that fits into that category of potential modification, even if the level is not low, we will check every 3 months just to make sure we're on top of it. If they have a stable level, then we'll go to every 6 months, but initially, usually for the first year, we will check it every 3 months. And then obviously if the level's low, you do want to keep repeating it until you can get it normal while you're modifying the PN. Zinc and selenium are the same also. We'll check it 1 month after PN initiation. And again, I put 6 months on here, but a lot of times we are checking it every 3 months in the beginning. And then once we see that it, is remaining normal, then we'll go to 6 months. And if the level is low, usually we repeat it before 2 months, just depending on where it's at. Your vitamin D, checking every 3 to 6 months if deficient. And the right side of the column, I know we're talking about parenteral nutrition dosing, but it's just a nice reference to have once these patients transition off parenteral nutrition, and if they're transitioning onto enteral nutrition, and you say, okay, when should I check these labs after they're completely off parenteral nutrition? So I went ahead and I left that on there just for a reference. Vitamin E and A, we check once a year. If we know that they are deficient or if they're likely to become deficient, given their condition, we might check it every 3 to 6 months. So our patients, usually stable ones, will do every 6 months, but some of these patients that aren't so stable, they have high losses, we're trying to figure out different medications to help them, we're tweaking their TPN, then we'll usually check it every 3 months. B12, it says yearly when they're on parenteral nutrition, but this, you want to just make sure that you know the patient and what's going on, and are they at risk for becoming deficient. So checking that B12 and MMA, it might need to be more often than yearly. An essential fatty acid panel, checking every 3 to 6 months while they're on PN. If they are deficient, we will modify the lipids, and I'll touch on this later, but we'll modify the lipids and then we'll check again in 1 month after that change to lipids has been made, just to see if it does correct. And if it does correct itself, then we'll check it every 3 months. Chromium and manganese, we will check them once a year if that, but that's something that if you're going to check, you really just need to check once a year. So now to go on to lipids. So as we know, lipids are an important source of energy. This is where you're going to get the bulk of your, they provide the most energy for us in our PN. They also have they give us the ability to reduce dextrose load so we can meet those caloric needs. If you have those patients that are at risk for hyperglycemia, if they have diabetes, if they can't tolerate a lot of dextrose, if you're continuously having to give them insulin because you can't get their blood sugars under control, that you have these lipids that you do provide energy, so you can reduce that dextrose load. again, reducing side effects from hyperglycemia, and lower CO2 production, which can increase, as we know, if you're giving excess dextrose. We have had patients that have come to us getting a lot of dextrose that you kind of look at and you're like, whoa, that's way too much, and they may only be getting lipids like 3 days a week, and there's no reason they're getting lipids 3 days a week or a lower amount to not meet their needs daily. So you look at that and you look at their labs and say, you know what, we have room to, I see these labs, they're hyperglycemic, their CO2 levels are off, like what can we do? And you may say, okay, they have a lot of dextrose, let's lower the dextrose and let's increase the lipid amount daily, or let's change it to 7 days a week. So you can bring down that dextrose. And as we know, it provides essential fatty acids, which are important for growth, development, and function, especially in our pediatric patients. The whole goal with them is to get them to grow. So you want to make sure you are providing them the essential fatty acids that they need for their growth and development. So just to touch on some of the important points of these different oil sources, your soybean oil is going to provide you with the essential fatty acids. MCT rapidly oxidizes, so it can provide immediate energy to your body. It does not accumulate in the liver, and it clears, it has a fast metabolic clearance. Your fish oil is providing you with omega-3. It is considered conditional. It has some essential fatty acids, not like soybean, but it's less pro-inflammatory, and it does have some potential anti-inflammatory activity. Olive oil is going to provide your omega-9. You will get a small amount of essential fatty acids from the olive oil, and it's also immune neutral. So these are your lipids that are available in the United States. You're going to have intralipid and neutral-lipid, which is 100% soybean, and this is FDA approved for adult and pediatric populations. You're going to have your SMOF lipid, which is the combination of soybean oil, MCT, olive oil, and fish oil. This is FDA approved for adults, as well as clinolipid. This is primarily olive oil with 20% soybean oil. It is approved for adults as well by the FDA, and omega-vin. This is 100% fish oil, and it is approved for pediatric patients. So your soybean oil, here are the indications for it. As we know, it's going to provide 10 calories per gram. It does provide all of the essential fatty acids, and it is used in the treatment of essential fatty acid deficiency. So if you have a patient that has essential fatty acid deficiency because they haven't been getting any lipids, they haven't been getting enough lipids, the type of lipid wasn't providing enough, then this is something that you can treat essential fatty acid deficiency with. Contraindications are going to be triglycerides over 1,000 and an allergy to soy, egg, or any of the other active ingredients. Other potential use for this would be short-term lipid needs. So if you have a patient that it's not going to be a long-term PN patient, they just might need it for a few weeks, a month or two. It's not going to be extending for like 6 months, a year, 2 years. This is something that you can use for them for short-term needs. If you are using it though, prior to starting it, you do want to make sure they have normal liver function tests. If you have a patient that has high liver function tests, their liver is not good. They may be a patient that's already in liver failure, awaiting transplant, that this is not a lipid you want to start. You want to look at your other options and say, hey, which one can I start for this patient because they don't have normal liver function tests. Again, you can also use it in the treatment of EFAD, and the dosing requirements do meet essential fatty acid needs. So here's your dosing for soybean oil. For the adults, if they're a stable hospital patient, if they're at home, if they're a long-term PN patient on this because you've chosen to use it or this is all that's available for a long-term patient, you want to dose them at 1 gram or less per kilo per day. In the ICU, you want to avoid it or limit it the first week. Your pediatric patients, you can see it's quite the range. It's going to be 0.5 to 3 grams per kilo per day, dependent on their age and their weight. And then you can advance their infusion rate by 1 gram per kilo. So if you have a pediatric patient that you're needing to provide more of, let's say you need to provide them, 1.5 or 2 grams per kilo, you're not going to want to start them right away at goal. You want to make sure you're advancing it. And then your infants, your tiny ones that are less than 750 grams, you'll advance by 0.5 to 1. And you just want to monitor their triglycerides to make sure that they're less than 250 prior to advancing. With soybean oil, you want to monitor their triglycerides, bilirubin levels, and again, their liver function tests. Your olive oil and your soybean oil combination, this is, here are the dosings for that. Your adults are going to be 1 to 1.5 with a maximum dose of 2.5. It's going to be dependent on, again, it's a high range, but if this is the lipid that they're getting, let's say that you're meeting obviously their protein needs, can't give them too much dextrose, but they need some more calories. This is why you have that range. So if you need to go up to 1.5, you can. It does provide 10 calories per gram, and it does, if you need to provide essential fatty acids, this is indicated for that. Again, contraindications are going to be triglyceride levels greater than 1,000 and any allergy to soy, egg, or the other active ingredients. It is off-label use for pediatrics. With this lipid, you want to monitor their triglyceride levels, their bilirubin levels, and their liver function tests. For essential fatty acid, just because it is that split lipid, it's not providing 100% of essential fatty acid needs. So just monitor for signs and symptoms of EFAD. And then order a panel per your institution protocol. Again, every institution has a different protocol, like I stated earlier. If this is something that you think they might have essential fatty acid deficiency, go ahead and or go ahead and get a panel just to see where they are. Your combination of soy, MCT, olive oil, and fish oil, as we know, is SMOF. It provides 10 calories per gram. It does provide some essential fatty acid, and it is currently off-label in the U.S. for kids. However, there are kids. There's a lot of pediatric patients that are on it. It's on label for adults, but you will find a lot of pediatric patients that are on it. Potential use for this is going to be your long-term PN patients. So it's going to be greater than 2 weeks. These patients are going to be on for the long haul, for several months, for potentially a year or 2 or longer. This is something that you could switch to because it's going to be easier on the liver. If you have a patient that's in a constant inflammatory state and they are on PN and they might be on another type of lipid, but they have that constant inflammatory state given their condition, this is a lipid you can consider switching them to because it does have the combination of all the oils. Your patients with elevated LFTs, this is another one that you could switch to. So if you see that patient that comes to you, they're PN dependent, they have lipids, and they have elevated LFTs, you could switch them to this. Elevated triglycerides are also a potential use. And then dosing does meet essential fatty acid requirements if you dose it correctly. So here's the SMOF dosing. I did put pediatrics, it is off-label for pediatrics, but it is used a lot in the pediatric population. Adult SMOF dosing is going to be 1 to 2 grams per kilo per day, and it needs to be at least 1 gram per kilo. I can't stress this enough. We have a lot of patients on SMOF, or they come to us on SMOF, and they're getting 0.8 grams per kilo because that's what we do with a soybean lipid, or they're getting 50 grams per day because that's what we do with a soybean lipid. That's not going to meet their needs. They need at least 1 gram per kilo per day. You don't want to exceed 2.5 grams. In my practice and with our patients, we usually average around 1.5 grams per kilo per day. That's what we find meets their needs, helps them maintain their weight or gain weight if we need them to gain weight. So we usually fall right in the middle, but we have gone up to 2 grams per kilo per day in our adult patients. And again, you're just monitoring their labs. As long as, monitor their labs, they're tolerating it fine. It's okay to give that much. You don't have to have that mindset of, oh, I'm going over 1 gram per kilo. It's not good for them. This is a nice lipid that you don't have to minimize for liver protection. Pediatric patients, you want to provide 30% of their total calories. And I did provide in this chart, depending on the age of the patient, what you need to provide. So if they are a preterm infant, you want to give them 3 grams per kilo per day. That's going to be their goal. You really don't want to give them less because you're not going to provide, again, we need lipids for growth and development. So you want to make sure, these little tiny babies, start them off right. Start them with the lipids that they need and not minimizing it. Your term infants are going to be 2.5 to 3 grams per kilo. Children between 1 and 10 will range from 2 to 2.5. And again, you can see these term infants and children do have a range because they might not need, the full, the higher end of the range because it might be too many calories for them. But you want to make sure you're not going under the range if they are solely dependent on PN and lipids. Your adolescents, you're going to provide 2 grams per kilo. And when you advance, for infants and children, you'll advance by 0.5 to 1 gram per kilo per day. And your adolescents and your adults, you can go 1 gram per kilo per day. So the administration, it depends on their age. And again, like we talked about way back in the beginning, you do want to make sure the lipid infusion rate, that you're not exceeding that. So these are the recommendations for adults, neonates, and infants and children. However, there are studies that have reported a maximum lipid infusion rate of 0.17 is okay, and they do not see any harm in that. So you will have, you can monitor it, and if that lipid infusion rate is exceeding, is not, if it's around 0.15 or 0.16, let's say, then if they need that, if they're tolerating it fine, it's okay to go a little higher. But again, you want to stay, the maximum rate would be 1.17. Monitoring, monitor their triglycerides, their bilirubin levels, and liver function tests. For essential fatty acid, monitor for signs and symptoms of EFAD. And if you do see that they have signs and symptoms, then order that EFAD panel. Or if your institution, again, has a protocol that you monitor it every 3 months while they're on lipids, then do that. Just making sure you do keep an eye on it. So for fish oil, this is the indications for this. It is a source of fatty acids for pediatrics with PNAC. Potential use would be conjugated bilirubin greater than 2. Other potential use could be an allergy to soy, olive oil, palm oil, or coconut oil, or an intolerance to other lipid. I can say we use this because we do have patients with PNAC, but we do have some patients that, since this has been approved, they do fall into that potential use category because they do have an allergy to soy, to other oils that are found in other lipids. So this has been a good alternative for us to use it with those patients that couldn't tolerate another lipid, but they do need the lipids because they're PN dependent. So we have used it for the patients with allergies or intolerances to other. But if you are using it, if that bilirubin, you see that bili going, greater than 2, this is something to keep in mind. To use contraindications would be an allergy to fish, eggs, or other active ingredients, and triglyceride levels greater than 1,000, as well as hemorrhagic disorders. And it's important to know that this is not for prevention of PNAC. So you're not going to say, oh, this is something that if you have a patient with PNAC, this is a source of lipid fatty acids for them. It is not to prevent it, but it is a source for the patients that already have PNAC. And this provides differently. This provides 11 calories per gram. Again, it's approved for pediatrics, so I put the pediatric dosing only on here. It is 1 gram per kilo per day, and this is the maximum dose. Our patients that we have on this, I don't think we put them on 1 gram. We haven't gone lower. We obviously don't go higher because one's, being the maximum dose, but they usually do fine just with the 1 gram per kilo. You want to monitor their triglyceride levels, bilirubin levels, liver function tests, and make sure you're monitoring coax too when they're on this. I did want to touch on essential fatty acid deficiency since we have gone through all the different types of lipids and talking about this, that if you provide less than 1 to 2% of total 1 to 2% of total calories provide essential fatty acids. You can also see this deficiency occur in patients with severe fat malabsorption, and patients might have increased requirements due to their growth, so those pediatric patients. If you are ordering an essential fatty acid panel, it's important to note, depending on, you get all sorts of ranges for the TT ratio, but really it's if it's greater than 0.2, that's the biochemical marker and the indication for it. Symptoms may include dry skin, flaky, scaly skin, cracking, peeling of fingertips, bumps on the back of the arms, dandruff or cradle cap, impaired growth if you have patients, your PD patients that aren't growing well. That could be a clinical symptom if you see dry eyes or impaired vision or any kind of neurological changes. So if you have patients that are complaining of these symptoms and they are on lipids and you're not sure if they're getting enough or the right type, if they come to you with these symptoms, you should order an essential fatty acid panel. That's something that should just click right away and say, okay, I know these are some of the clinical symptoms. Let's go ahead and order a panel to make sure they are getting enough. You can prevent it by providing 2 to 4% of total energy from linoleic acid and 0.25 to 0.5% of total energy from alpha linolenic acid. And with the lipids, you just want to make sure that they're stable. You want to look for any of these listed, aggregation, creaming, oiling out, just keeping an eye on the bag. And when they're in the hospital, it's easy, but also educating, your home PN patients that are on lipids. And one other thing to point out is fat overload syndrome. This can happen when you're giving excess accumulation of serum lipids. So, if you have a patient that is feverish, jaundice, irritable, has spontaneous hemorrhage, hyperlipidemia, lethargic, you want to think of this. Some of the instances that, we have thought about this and it's come to our mind is because the patient may have infused the lipids too fast. They hooked it up to the wrong pump and they gave it in 2 or 3 hours versus 12 hours. So just keep this in mind, especially for our patients at home. If they call and say, oh, I just infused it in the wrong pump or went in too fast, just, ask them if they have any of these symptoms. And that concludes my presentation. Are there any questions?
Thank you, Kathleen. We actually do have a few questions from our audience. The first question is, why would high protein require more calcium?
So I cannot speak personally on this, but the patients that that have higher protein amounts, when we are checking their calcium levels, they are coming lower, their adjusted calcium. I am not going to sit here to try to answer that completely. I just know it's something that in our practice and with our physicians and our other team members, that is something that they have noticed. More so, I would say in our renal patients.
Okay, thank you. And our second question is, for renal adult patients, what is your recommendation for trace elements? How many times per week add for PN?
You cut off how many what?
I'll repeat that question. It is for adult patients, what is your recommendation for trace elements and how many times per week should be added in parenteral nutrition?
For the renal patients, so for our renal patients, we get a baseline, their trace element levels, and depending on what they are, we add it daily. So we don't, unless we see, if there's levels that are obviously high, we'll remove multi-trace element and we'll add individual trace elements. So if they have one that's high that they may not necessarily need, instead of limiting multi-trace to 3 days a week or 4 days a week, we will just add the individual trace elements that they need. The same if they come back. Our view is we don't want to limit it, because if you have one level that's off and you're limiting multi-trace to several days a week because of one level that's off, then you're going to put the other elements at risk. So instead, what we do is we get the levels and then add individual if we need to daily.
Okay, thank you. Our next question is, what is the cost comparison of various lipid products?
In our institution, inpatient, it's virtually the same. There's not a huge cost difference. Within like several dollars inpatient, I can say, between using a soybean or a SMOF lipid or omega-bin, because we have all of them inpatient. So for us, it's not a huge cost difference, within like $5, $10 range. Outpatient, it is different. I mean, probably the home infusion companies would have to touch on the outpatient part. We have run into problems trying to get patients approved for different lipids, that they come back and say, you know, omega-bin's more expensive than SMOF, or using a soybean, 100% soybean.
Okay, thank you. And our last question is, what should we do in case of fat overload?
So if you are concerned for fat overload syndrome, we tell them to immediately go to the ER, have their levels checked and be monitored. It's a no-brainer for us. Even if they tell us, oh, well, I kind of feel fine, I might be tired, but I don't know if it's because the increased, like the excess infusion time, but we just say, hey, if it infused too fast, if you have these symptoms, go to the ER, be monitored. That way we know that nothing's the matter.
What kind of testing would they do in that case? Are there any specific labs to look out for?
So they'll monitor their triglycerides, they'll monitor their LFTs, depending on where they go. We'll do, they do several different tests in RER, depending on if it's adult or pediatric, and then monitor their physical signs and symptoms as well. So I with jaundice. So if you have a patient that, you know, is never really jaundiced, but now all of a sudden looks jaundiced, their eyes are a little different color, then, you know, that might be a symptom of, okay, you did it, you got too much, let's just monitor this to make sure it comes back to normal.
Okay, thank you. And I do have one last question. What lipids, actually I have two questions. What lipid would you recommend if a patient is allergic to eggs?
Our egg allergy, we have had, that's a tough one, because you have to see if, you know, what are the other, like, are there traces of that? Because all lipids are going to have, they're going to have egg in them. So then if you have an egg allergy patient, probably not going to have a lipid you can give them. If they need those essential fatty acids, because they are on PN and can't get any lipids because they have eggs, you can do a test dose. So we have had a few pediatric patients that have an egg allergy, and what we do is they go see an allergist, and they come to us. We do a test dose in the hospital just to make sure they tolerate it. And if they do, if you do a test dose in the hospital, and they do have a reaction to it, you can't give it to them. You have to find alternative sources of fatty acids that aren't going to be from the lipids.
Are there any that you would recommend?
Alternative sources of essential fatty acid. So we do safflower oil. Yeah. Our recommendation is usually safflower oil to give topically, rub it on topically twice a day, or giving it, you know, if they have a tube, you can give it through the tube. Some will mix it with a formula if they're able to take a formula. But the kids that don't absorb, or even the adults that don't absorb any, we would recommend safflower oil topically.
Okay, thank you. And then lastly, Is there a slide with all of the references? Because some slides do not have a reference at the bottom of the slide. So could you send us one with all the references and we can send it out to the attendees?
Yeah, not a problem. Yeah, I can almost definitely do that.
Thank you. And if anyone has any other questions, you can post them in the question field. We'll give everyone just a few more seconds to submit any questions if they have it. Okay, and you can always email us with more questions. I'm sorry, Kathleen, go ahead.
To touch base on the calcium, your high amino acids will increase calcium excretion. So you're going to lose a lot of, you're going to excrete more calcium if you have higher amounts of protein that you're giving to a patient. So just again, something to keep in mind.
Okay, thank you, Kathleen. And once again, if any of our attendees have any other questions for our speakers, you can email them directly, or you can email us at gaspinga@gmail.com, and we can send those questions along to our speakers. Thank you so much, Kathleen, for your presentation.